Hi guys, welcome to canceracademy.org. Goal of this video is to understand a basic information about common cancer, to improve your knowledge about cancer, and remember, knowledge is power and power is what we need to beat cancer. In this advanced version of demystifying breast cancer, we are going to discuss detailed information about breast cancer treatment. The goal of this video is to discuss about pathology of breast cancer, type of surgery required, who needs radiation therapy, chemotherapy, hormonal therapy, or targeted therapy. Now, we did discuss about stages of breast cancer in previous version, but I think I'm going to summarize it again so the treatment decision is somewhat easy to understand. Stage 0 or non-invasive cancer where cancer cells have not broken its wall. Stage 1 when tumor is less than 2 cm and negative lymph nodes. Stage 2 is where tumor is between 2 to 5 centimeters or up to 3 lymph nodes positive, or if tumor is more than 5 centimeters but no lymph nodes positive. Stage 3 is where tumor is larger than 5 centimeter and lymph node positive, or tumor is fixed to chest wall, skin, or 4 or more lymph nodes are positive. Stage 4 or metastatic breast cancer is where it has metastasized to bone, lung, liver, or brain. Now, pathologists will check several additional testing in addition to diagnosis of breast cancer, which includes hormonal testing such as estrogen receptors and progesterone receptors. In addition, they will also do testing called HER2/neu, which is a target which is identified on breast cancers, and they can also do some genomic testing called Oncotype DX, which is a 21 gene assay, and it's used to determine the risk of recurrence. There are two types of surgical options. One is lumpectomy or mastectomy. Lumpectomy is where tumor with some healthy tissue around has been removed, and mastectomy where whole breast has been removed. If you look at it, there is no overall difference in cure rate. So most of the time it's a patient's preference and whether they would benefit from radiation or not. At the time of surgery, your surgeon will also determine whether lymph node is involved or not, and they typically do something called sentinel lymph node biopsy. Now, sentinel lymph node is the first lymph node where cancer spreads prior to spreading to other lymph nodes. If sentinel lymph node is negative for cancer, there is no need to remove additional lymph nodes. If sentinel lymph node has a cancer, they remove additional lymph nodes in armpits. Now, radiation therapy is done in any patient who underwent lumpectomy, or if tumor is more than 5 centimeters in size, positive margins, skin involvement, tumor was fixed to chest wall, or lymph nodes have cancers, or there is a extracapsular extension in the lymph node. Before we start talking about medical treatment, some of the nomenclature is important to understand. Adjuvant treatment is a treatment done after surgery, and the goal of this treatment is to kill any microscopic cells left behind at the time of surgery. Neoadjuvant treatment, which means the treatment is done before surgery, and the goal is to shrink tumor if it is large. So if someone would have required mastectomy and if tumor shrink, possibly they could consider lumpectomy. It also helps determine whether cancer cells are sensitive to chemotherapy, and if after surgery, if you do not feel that tumor has responded the way you expected it to do, you could potentially place them on some sort of clinical trials after the surgery. So it gives some prognostic information. Now, medical treatment includes chemotherapy, hormonal therapy, targeted therapy, and clinical trials. Chemotherapy has approximately 30% chance of reduction in cancer recurrence rate. So the benefit of chemotherapy is higher if somebody has higher risk cancer. Chemotherapy is typically done if somebody has a higher stage tumor, larger tumor, ER or PR is negative, HER2/neu is positive, or Oncotype DX result shows that someone has a higher risk of recurrence. And age and overall health status will also be important. And combining all those features, oncologist typically determines the risk of recurrence and then decides whether there is any risk versus benefit of chemotherapy. Hormonal therapy is given to the patient who has either estrogen receptors or progesterone receptor positive. It helps recurrence in the same breast, other breast, and distant metastases, and typically has approximately 50% risk reduction in recurrence rate. Hormonal therapy is dependent whether person is a menopausal or non-menopausal, and tamoxifen can be given to either premenopausal or postmenopausal. Aromatase inhibitor is only beneficial in postmenopausal women. Now, again, aromatase inhibitors are approximately 25% better than tamoxifen. So in postmenopausal women, typically aromatase inhibitors such as Arimidex, Femara, or Aromacin is most useful. Targeted therapy is given to someone who is HER2/neu positive, and again, it reduces the risk of approximately 50% or so, and the option includes Herceptin, Perjeta, Kadcyla, or Tyker. Clinical trial is very important. If it is available, uses latest research and technology, helpful in finding new cures. Latest clinical trials information can be obtained from visiting clinicaltrials.gov. For additional resources, one can go to nccn.org, cancer.gov, cancer.net, or clinicaltrials.org. Thank you very much for watching this video. Cancer and its treatment is complex, and to make it simple to understand, I have simplified some of the staging and treatment decision making. So make sure to consult your physician before making any treatment decision. If you found this video helpful, please share it with your friend and family, and please leave a thumbs up. If you have any further question or comment, please make sure to leave a comment at the end of the video. Thank you.